Disclaimer: all animations are hand drawn and all microscopic images, videos, imaging data, culture plates are from Sri Ramachandra.
Here displayed is an e-poster on mucormycosis.
We are Team D3 here to present about mucormycosis. We all might have heard about this infection in the COVID-19 pandemic. So, what is mucormycosis? It is a rare but serious angio-invasive infection caused by the group of fungi called Mucormycetes of the Zygomycete family. These are of different types, which includes cutaneous, gastrointestinal, pulmonary, and rhinocerebral, of which rhinocerebral is the commonly reported form. After COVID, the situation has become worse. 81.1% of all global cases of mucormycosis in COVID 19 is from India, which appears to be an unholy intersection of trinity of diabetes, rampant use of corticosteroids, and COVID 19. It is characterized by tissue necrosis due to invasion of blood vessels and subsequent thrombosis, usually followed by rapid progression, and it might be fatal. The given pie chart depicts incidence of various fungi causing mucormycosis, of which Rhizopus oryzae is the most commonest form, followed by Apophysomyces elegans, Apteria corymbifera, Saxony vasiformis, Rhizopus microsporus, Rhizomucor bacillus, Mucorracimosis, and Syncephalastrum racemosis. Mucormycosis is an opportunistic fungal infection, and various underlying conditions can predispose the host towards infection. The various risk factors include diabetes with diabetic ketoacidosis, neutropenia, injection drug use, long-term corticosteroid use, stem cell transplant, cancer, organ transplant, skin injury due to surgery, wounds or due to burns, too much iron in the body, and low birth weight or prematurity.
Falsely believe that mucormycosis is contagious. On the contrary, its transmission takes place via four routes: inhalation of the spores, ingestion of contaminated food, implantation of the spores on open wounds, burns, and somatic disruption, inoculation through contaminated catheters, needles, and adhesive bandages.
Fever, cough, headache, chest pain, stomach ache, shortness of breath, bloody stool, GI bleed, diarrhea, black lesions in the nose and the mouth are all symptoms of mucormycosis. Prominent feature of mucormycosis is its angioinvasive nature. Now let us look at its mechanism by going through the vessel wall. Mucor binds to GRP78 proteins and invades it.
Mucormycosis develops exclusively in immunocompromised patients who lack defense mechanisms due to inefficient macrophages, monocytes, and neutrophils. Acidotic conditions decrease iron binding and disrupts the capacity of transferrin to bind iron by proton-mediated displacement of ferric ion from transferrin. Fungi can obtain iron from the host by using high-affinity iron permeases or low molecular weight iron chelators, leading to fungal proliferation. Glucose-regulated protein 78 or GRP78 is a receptor promoting the ability of mucorales to penetrate endothelial cells. Increased concentrations of glucose and iron seen during diabetic ketoacidosis results in invasion and damage of endothelial cells, causing tissue necrosis.
Now we come to the diagnosis, which in most cases is done post-mortem. There are three types of diagnostic techniques which are being used. First, biopsy, second, culture, and the third one is imaging techniques like MRI or CT. MRI is used to check for extent of the necrosis, which is seen as hyperintensity. In post-contrast scans, absence of enhancement shows characteristic angioinvasive nature of the fungus. Apart from this, a black turbinate sign could help with an early diagnosis of ROCM. A CT scan is particularly helpful in diagnosis of pulmonary mucor, as there is a reverse halo or bird's nest sign, which can be paired with a bronchoscopy to see the extent of necrosis. Another diagnostic technique is performing a culture, which is specifically done to know the species of Mucorales. These fungi generally lift the lids of the culture as they grow and have a salt and pepper appearance. Lastly, a biopsy should be done with the tissue involved with histopathological examination, which is the most sensitive and specific modality. It shows characteristic wide, thick-walled, ribbon-like aseptate hyphal elements at right angles. KOH wet mount is done for the sample and aids in quick diagnosis for a timely treatment.
And here we have a rhizopus growth over 3 days captured under a microscope. Just like the diagnosis, the treatment also involves 3 steps. The first step is early initiation of therapy. If mucormycosis is suspected, initial empirical therapy with a polyene antifungal agent should be started while waiting for the confirmation. 2 drugs to which mucormycosis is resistant are fluconazole and voriconazole. The first-line antifungal treatment is liposomal amphotericin B, 5 to 10 mg per kg once daily, as it is less toxic even at higher doses. It works by binding to ergosterol in the fungal cell membrane that leads to formation of pores and ultimately fungal death. The second line or the salvage option is the use of posaconazole 200 mg 4 times a day, as it has an in vitro activity against the mucorales. The second step is rapid reversal of underlying predisposing factors like diabetes or a person on corticosteroids. The third step would be surgical debridement and excision of the tissue from the affected area, which has been found to be useful when combined with antifungal therapy.
Now we'll be seeing the case of a 27-year-old male who was admitted in the ENT department of SRMC. He was diagnosed with COVID 28 days prior to this and was put on steroid treatment. He developed hypoglycemia and low immunity. He presented with loss of vision in both the eyes and ptosis. MRI and CT scan was taken, in which it was seen that the frontal, sphenoidal and ethmoidal sinuses were involved. Medial temporal lobe lesion was seen and the right carotid artery was completely occluded. Treatment included endoscopic transsphenotemporal lobe dissection and removal of necrotic tissue from the temporal lobe. Prosthetic face reconstruction was done and the patient made considerable recovery.
Now for some information associated with COVID-19. Uncontrolled blood sugar, the use of corticosteroids and immune suppression are all important risk factors in developing mucormycosis. Most cases were reported in India and were linked to the infection with the Delta variant. COVID-19 often caused endolithiasis, endothelial damage, thrombosis and reduction in CD4 and CD8 levels, thus predisposes opportunistic fungal infections. Worse outcomes are associated with poor glycemic control despite aggressive medical and surgical interventions. The patients were admitted for severe COVID-19 pneumonia and acute respiratory distress syndrome 1 to 4 weeks before the diagnosis of mucormycosis. The patients received high dose of dexamethasone once daily for duration of hospital stay despite having poor glycemic control. Nasal endoscopy showed edematous and dusky necrotic mucosa. Fungal cultures of tissue biopsy specimens from nasal turbinate and septum were taken, inoculated on SDA and incubated at different temperatures. Management involved bringing diabetes mellitus and ketoacidosis under control.
The e-poster and the video clearly depicts the diagnosis and treatment of mucormycosis. The case was sourced from the ENT department of Sri Ramachandra Hospital. Special thanks to Dr. Prasanna Kumar. Following is a video of a surgery which was the first of its kind to ever be performed in India. It showed the transnasal endoscopic removal of necrotic fat from the orbit.
Now let us see a video of the surgery performed on this patient.